Hello, my name is Dr. Scott Berman, and I am the psychiatrist at Holcomb Behavioral Health Systems in Allentown and Easton, Pennsylvania. I will be talking about anxiety medications, in particular benzodiazepines, chronic anxiety, and how benzodiazepines can be reduced or discontinued without an increase in anxiety. We all know that in our society, people often turn to medications, especially psychiatric medications, as well as food and snacks, to counter excessive chronic anxiety. We also think that psychopharmacology can handle our anxieties when, in fact, there are many better alternatives in most cases. Benzos is the slang name for benzodiazepines, which include Valium or diazepam, Klonopin or clonazepam, Xanax or alprazolam, Ativan or lorazepam, Restoril or temazepam, and Librium or chlordiazepoxide. They all work at the same GABA A receptors in the brain, increasing sensitivity to GABA or GABA aminobutyric acid, which is an inhibitory or calming neurotransmitter in the brain. They do, however, have different potencies and also different half-lives for how long they stick around. Klonopin is the most potent, such that only half a milligram of Klonopin is equal to 10 milligrams of Valium. Xanax and Ativan are still more potent than Valium, while Sirax and Librium are less potent. These are important things to know if you are tapering or crossing over from one benzo to another. Benzos are used for the short-term, rapid relief of anxiety, for alcohol withdrawal syndromes, to prevent seizures, and as muscle relaxers. The benefits of benzodiazepines are that they have a rapid onset of action, they are very reliable, they are quite safe, and hard to overdose on when used alone, often associated with overdoses with both alcohol and opiates. There are no real alternatives for short-acting and quick-acting anti-anxiety medicines. The older ones, such as barbiturates, are much more risky, and the newer ones that we tend to use to avoid addictive medications, such as Seroquel or quetiapine, hydroxyzine or Vistaril, Neurontin or gabapentin, and Lyrica or pregabalin, all have side effects and modest efficacy. In a large study, they found little tolerance. That is, most responsible users under supervision do not need increasing doses year after year to get the same basic anti-anxiety benefit. Some patients do require them over the long term and would be harmed by stopping them. All medications have long-term risks. We need to remember that we look at the overall negative view of benzodiazepines. There's no need to shame or blame the patient who does need them or has used them. The risk of long-term use can include sedation, falls, cognitive or memory problems, addiction, and most important for our discussion today, they can increase chronic anxiety. This is not through a neurochemical pathway so much as a psychological one, that the more they are used, the less the person acquires alternative skills, and they stay chronically anxious. Anxiety, like all psychiatric syndromes, is defined by four sorts of symptoms: affect or feelings, behaviors, cognition or thoughts, and symptoms which are physical, such as shortness of breath, chest pain, sweats, and blushing. The ABCs of anxiety include affect or feelings such as fear, dread, apprehension, behaviors such as escape, avoidance, distraction, safety behaviors such as taking a benzo, cognitions that I'm going to die, this is terrible, I can't handle it, people are laughing at me, and physical symptoms including rapid heartbeat, shortness of breath, dizziness, red face, sweats, and nausea. Anxiety becomes chronic through a behavioral cycle. There is a trigger, such as a generally anxious person who sees a test coming up and becomes very worried. They will tend to overestimate the probability of a bad outcome, such as a student saying 100% chance I'll fail, and they overestimate the cost of what would happen if that probability comes true. So an anxious student will say, overwhelmingly likely I will fail, and if I fail, I'll get kicked out of college or have to repeat a year. While a non-anxious person might say there's a chance I would fail, and if I fail, I'll simply take the test over. Once the worrying starts, there's efforts to stop the worrying, search for relief, which can include taking benzo, failed problem solving with the belief that one can handle it, and come the next test or the next trigger, the person's just as anxious as ever. Benzos cause increased anxiety because the person taking them knows they're using them to reduce their anxiety, which cycles back to them knowing they need a safety behavior, which then leads to them continuing to believe they have the inability to handle the situation, and believing that one cannot handle a situation leads to increased anxiety. Panic attacks also cycle in the same way. There's a trigger such as shortness of breath or pounding heart, a catastrophic misinterpretation such as I'm sick, I'm having a heart attack, hypervigilance, scanning for symptoms, checking one's pulse, listening to one's breath, chronic anxiety, worrying about a future attack, and indeed anticipatory anxiety or worrying about the next attack is a cardinal feature of true panic attack disorder as opposed to a limited attack, as is agoraphobia or avoiding places so as not to have an attack. Benzos come in as a safety behavior, and one feels less safe because they feel that without the benzo in their pocket, they're pretty helpless and at risk. There are different cognitive distortions depending on the anxiety disorder. Someone who's generally anxious might think I'm going to lose my job, I'll end up homeless, it's all falling apart. Social anxiety patient will think people don't like me. People may notice my anxiety and think I am weak. Panic attack patient, again, I could have a heart attack, and they're fearful of the fear itself. Specific phobias, the plane could crash, I could choke, I could fall off a high place. OCD revolves around believing in the need for the compulsion. If I don't count to 4 each time I feel anxious, something bad will happen. In PTSD, the distortion is that the world is entirely a dangerous place and I cannot keep safe. We all do things to keep ourselves safe. We put on winter coats, we put on a seatbelt. But safety behaviors, or properly false safety behaviors, are a response to a threat that is exaggerated or not really there. And thus, the false safety behaviors increase our sense of anxiety and danger. Types of false safety behaviors. Avoidance. People will avoid activities, situations, objects, heights, enclosed spaces, needles, parties. They'll avoid certain bodily reactions. A panic patient may not exercise so they don't feel their heart beating fast. Avoidance of negative thoughts and memories, particularly seen in PTSD patients. Checking stoves, locks, the location of exits, the location of bathrooms, pulse, blood pressure. Checking your work over and over again in a generally anxious person. Mental maneuvers, self-reassurance, distraction, reanalyzing events, rumination. Use of safety aids, carrying rescue meds, water, food, inhalers, antibacterial lotions, phone numbers, having somebody go with you when you go out. Reassurance seeking, continually asking your partner, friends, boss, others if you're all right. And again, safety behaviors, like cognitive distortions, tend to be specific to the disorder. A panic disorder patient may avoid driving or carry a rescue medication. A PTSD patient may avoid going out at night or carry a weapon. An OCD patient who's got a fear perhaps of harming someone else by accident might lock up all their knives at night. Somebody worried about relationship may look for constant reassurance. How benzos maintain and worsen anxiety, as do all safety behaviors. A misattribution of safety. They believe that the benzo prevented the feared outcome, such as a panic attack, or they believe in general that their safety behavior is why they were okay. It prevents threat disconfirmation, meaning they don't really learn that what's around them is safe because they never experience it. The benzo band-aid interferes with motivation and learning that could be curative, leaving them with dampened anxiety when they take the benzo with chronic fight or flight responses that are really unnecessary. And finally, negative reinforcement. The benzo reduces anxiety, which is a reward, which reinforces the wish to take it again. Misattribution. When people unnecessarily perform actions to protect themselves from a perceived threat, they falsely conclude or misattribute their safety to the false safety behavior, thus leaving their belief that the threat is real intact. For instance, you worry too much, it doesn't do any good. It does for me. 95% of the things I worry about never happen. And we see in people with generalized anxiety and other anxiety disorders, chronic incessant worry with the belief that The worry itself is why they stay okay, that it keeps their guard up and that nothing slips past them. Safety behaviors interfere with threat disconfirmation, which is what we see, for instance, in a young toddler who's fearful while waiting to sit on Santa's lap. Once they sit on Santa's lap, they realize there's no actual threat, so there's disconfirming sensory information, and they are no longer afraid. Avoidance prevents threat disconfirmation from occurring. The toddler who doesn't get on Santa's lap will be just as scared the next year. Safety behaviors, reassurance, taking a benzo, also disrupt the process of threat disconfirmation. For threat disconfirmation to occur, you must experience the feared activity. You must also process it. For instance, the flyer who's afraid of planes, if they spend the entire time on the plane shaking with fear, taking benzos, kicking back alcoholic drinks, and watching them to see if the wings are on fire, will be no better when they land. But the anxious flyer who talks to other passengers, observes that everybody else is sitting in relaxed ways, will learn something and their fear will go down. Safety behaviors also continue our anxiety, and when we act like there's danger, we activate our fight or flight circuits. So the safety behavior actually activates us in the way while we pretend that we're safe. Procrastination isn't usually laziness, it's a reaction and escape from anxiety. Avoidance, the great addiction. If you get a cookie every time you do something we ask you to, you'll do it more. This is positive reinforcement. If you get a Percocet after each painful physical therapy session, the pain goes down and you'll come back to therapy. This is negative reinforcement, or taking away something unwanted, in this case pain. When you get hit for doing something wrong, that's positive punishment. When we take away your cell phone or something you like when you misbehave, this is negative punishment. So, when you avoid something you fear, such as calling into work when you feel like you can't handle it, your anxiety rapidly goes down and you feel temporary relief. Avoidance is a negative reinforcement and you can get hooked on avoiding things. If the task or situation you fear will recur, you will be more fearful and require more avoidance in the future. Or you'll become permanently avoidant, such as somebody with agoraphobia who won't leave their house. Here's black belts in the ancient art of avoidance. Avoidance is seen in anxiety and depression. In the morning, anxiety is the voice that says, don't do it, it's dangerous, while depression is the voice that says, why bother, it won't work out. Then in the evening, anxiety is the voice that says, good thing you didn't do it because it would have been horrible, better not try tomorrow. And depression is the voice that says, look at you, you got nothing done, you're lazy and a coward, what a loser. So avoidance fuels anxiety and depression. It's the most crippling safety behavior. And here we see the attendance at the Agoraphobic's annual convention. Anxiety sensitivity. This is a concept that describes the increased reactivity of chronically anxious people to otherwise trivial stimuli. This is the Anxiety Sensitivity Index, a standardized rating scale that's used to discern this. So people who are have high anxiety sensitivity try not to appear nervous, become anxious when they feel shaky. That is, they become scared at small stimuli. They can be scared when their heart goes fast, or when their stomach growls, or nausea, or people notice them. Things other people might shrug off as fairly trivial. We see higher anxiety sensitivity and anxiety disorders. Gradual reduction of benzos while practicing anxiety management skills. So slowly we reduce the benzo while learning anxiety management, which includes cognitive reframing, that you can handle some things on your own and you're overestimating the risks, reduce scanning for danger, reduce chronic worrying, learning how to relax and get baseline anxiety down, and reducing anxiety symptoms over time. And here's the resistant patient saying, okay, maybe I need to change my life, or maybe you could just tweak my medication. And how often do we hear this? Life without benzos, time to graduate. Gradual reduction of anxiety drugs using alternative techniques. Now, these techniques are well described in other works, such as Stopping Anxiety Medications by Pollack and Otto. I've simply distilled them uh, into short and easy to learn chunks that we can use in our clinic setting. We expect everybody to work in this program at some level, and we expect it as no different than expectations of other doctors. Can we imagine a surgeon agreeing to replace a hip or knee in someone who won't do physical therapy, or giving diet meds or a gastric bypass to somebody who would not diet? The goals of our graduate program is to reduce 5 things all at once over time. To reduce the monthly or daily or weekly benzo dose, but at the same time reducing average daily anxiety and reducing anxiety to feared situations, reducing baseline anxiety sensitivity, and reducing safety behaviors. And if we can convince our patients that reducing their benzo is not to massage our charts for audits or some sadistic maneuver, but that we'll actually be better off over time with increased mastery, less anxiety, and perhaps in the future better responsiveness to small benzo doses should they need them again, we can be successful in this endeavor. Reducing anxiety sensitivity. So everybody should be working on getting their baseline anxiety down so it's harder to get all the way to the 10 out of a 10 where they get a panic attack. This could be through progressive muscle relaxation, meditation, aerobic exercise, or interoceptive exposure. And I'll talk all about those, but I should note that in some unpacking studies, and an unpacking study is a study in which different parts of a CBT program are taken separately to see what really works, you see that the exposure and safety behavior avoidance components, as well as cognitive restructuring, really outweigh just relaxation in terms of importance. You could actually skip relaxation exercises and just do cognitive reframing and exposure and get good results. The expectation is that everybody will commit to a relaxation techniques and they be practiced daily whether or not you're anxious. The therapist will be the accountability partner to ensure you practice. All forms of meditation work if you do them every day, in a calm, quiet place, have a focal point or a mantra, and a self-accepting attitude. That is, rather than criticizing yourself if your mind wanders, you gently bring yourself back into the moment. And very interesting, recently there was a study of using mantras in PTSD that was reasonably successful. Freud at a crossroads. Psychoanalysis should relieve stress and anxiety, but so does looking at fish. Again, simple things work. Breathing and progressive muscle relaxation. It's a good treatment if you have trouble visualizing. It's very concrete. You can listen to instructions on your phone with an app or YouTube or record a custom program with your therapist. You do need to do it every day. Just like any exercise, it doesn't work if you don't practice. It's good for people with a lot of muscle tension because you can actually feel the difference between your tense and relaxed states, something many of our patients don't really experience. Exercise reduces blood pressure and resting heart rate. It results in less of a physical reaction to stress with better tolerance of it. Improves sense of wellness and confidence. It is anti-anxiety and antidepressant. If you're over 40 or have high blood pressure, diabetes, heart disease, or joint or back problems, see your PCP first to be cleared. Find a place or time to exercise, and put down the potato chips and turn off the Netflix. A good starting point is to measure how many minutes of MVPA you do a week. MVPA means moderate to vigorous physical activity. Start at 150 minutes a week, that is 30 brisk walks for 5 times a week or the equivalent. And chart your progress. Yoga or Tai Chi is not as vigorous but may help anxiety and mood, but again, you need to do it regularly. Interoceptive exposure. This is used to treat the distressing bodily sensations and anxiety disorders. We often get triggered when we feel short of breath, chest tightness, dizziness, rapid heartbeat, or sweats. Interoceptive exposure stops the link between the sensation and becoming panicky. How? By bringing on the bodily sensations at will and under your control in the office, you become desensitized when you learn that the physical sensation is not the same as a catastrophe. With the therapist present, we can do things such as breathing through a straw or hyperventilating to bring on shortness of breath or dizziness, running in place or running stairs to bring on rapid heart rate and rapid breathing, spinning in a chair to bring on dizziness. The practice for increasing number of minutes with relaxation between practices. And once they're mastered in the office, they can be practiced at home. One exposure tip from a friend of mine who's a therapist. Buy a bottle of kids' bubbles and bring it with you. After an exposure, if you can't calm your breathing, blow bubbles until you relax. It's impossible to blow bubbles while hyperventilating because blowing bubbles requires very controlled breathing. Cognitive reframing. Look at the probability, that is the likelihood that something bad will happen, from 0 to 100%, and the cost. If that bad thing were to happen, what would it actually cost? And can we go from 100% chance it's a heart attack and I will die immediately to 1% chance and at the most I would go to the emergency room, which is still overstating a panic attack, but that's what we're aiming for. Pigeon Little, the sky is falling, the sky is, oh look, part of a bagel. Cognitive reframing. In vivo exposure, facing fears in real life. A list of all the situations or things you fear is made up. For each item, you rate the level of fear from 0 to 100. The list is rewritten in order from 0 to 100, and this is the exposure hierarchy, working on lower items till we get to higher items. Plan the homework with a therapist. No safety behaviors during the homework. No benzos or bringing a best friend. Process what happens. Look around and be mindful during exposure. Plan what you will do during the exposure in therapy in advance. Write down your results and share it with your therapist. Exposure only works if you learn from it. Again, the anxious flyer only learns if they engage with others on the plane. And here we go. Wow, look at that amazing view. You can literally fall out of the sky at any second. But this one's saying, oh boy, here come the peanuts. And that's when they start processing that there's no real danger. Anxiety reward stickers. Reinforce your patients when they do well at facing their fears. Putting it all together. I'm going to attack anxiety in multiple places. Cognitive reframing, relaxation, exercise, meditation, interoceptive exposure to reduce the baseline anxiety, get rid of safety behaviors, and then do real in vivo, real-life exposure. Helping patients graduate. We are not anti-benzo, but we do want you to recover and have a more permanent reduction in anxiety. We will not put anyone through physical withdrawal. The patient will be part of the planning. Some may get off benzos entirely, others may do simply aim for a lower dose. If the patient is successful on getting off benzos and there is a significant recurrence, we can use benzos again and taper again. The long-term goal is lower anxiety and lower benzo doses. Perfectly possible. Every patient needs to do a monthly benzo use chart to stay on benzos. They all need to use alternative techniques. The therapist is a key person in assessing readiness and helping the patient learn alternative techniques. The psychiatrist will do baseline vital signs, exam, anxiety screens, and watch for any withdrawal. The psychiatrist will set the tapering schedule in conjunction with help from the therapist. Vital signs and a benzo withdrawal scale will help us make sure the patient is safe at all times. We will check the Pennsylvania Drug Monitoring Program website to make sure that the patient is not getting benzos or other controlled drugs elsewhere. We may have to do urine drug screens on request to make sure no other drugs are being used. Alternative techniques. The books include the Treatments That Work series from Oxford University Press, which has separate manuals, including patient guides for each anxiety disorder, as well as the Stopping or Anxiety Medication, or SAM, workbook. There are websites that can be used and apps also. So finally, what are we aiming for? Psychiatrist says, eventually I'd like to see you be able to put yourself back together. And the person who has good, successful treatment of their anxiety will not be free of anxiety. They will have myriad skills that let them cope and regroup when they face future anxious events. Thank you very much.